So which of the following underlying lung diseases is most likely to be associated with the patient's presentation? Okay. So our patient's got a lung disease. 50-year-old man, he smokes, emergency department, shortness of breath, left side chest pain. Let's see, decreased breath sounds, hyperresonance on the left side. He has a large left-sided pneumothorax. Okay. Well, it's not going to be asthma because we're not going to have a pneumothorax with asthma. Let's see. Sarcoidosis, idiopathic pulmonary fibrosis, chronic obstructive pulmonary disease, and then bronchiectasis. So chronic obstructive pulmonary disease is definitely a symptom of smoking.
Good. I like your team so far. Good. So they call that a risk factor, right? So just to clarify, right? So anytime you read a question or talk to a patient, you're thinking about risk factors, okay?
Okay.
And that's why, in medical school, they always teach you, when you talk to a patient, your chief complaint, which is usually your first sentence of every question, is their chief complaint, right? And then you kind of go through their history of present illness, right? Your HPI, right? Like, when did it happen, right? When did it start? The acuity, chronicity, has it been getting worse, right? And then you ask them things like, allergies, past medical history, past surgical history, family history, social history. That's to figure out in that history, is there extra risk factors? Does that make sense?
Yes.
So,
Yeah.
and then the next thing is your exam, right? Obviously, your physical exam is super important because that's going to further support whatever differential diagnosis, and any kind of lab or imaging you do is also going to support, right? So, you have that risk factor of smoking here. So, in your mind, you should be like, okay, so this guy's a heavy smoker. Which diseases go with smoking, right? Because that's a risk factor.
Right. Okay. I'm not exactly sure which diseases go with smoking. I know COPD does.
Okay,
Idiopathic pulmonary fibrosis. Idiopathic means we don't know what caused it,
exactly.
right? So I'm not sure if that would be the right scenario for this patient
Okay.
because it seems like a 40-year packing smoking history would be like, you know, something that we would kind of know about, or a risk factor that, to a clinical thing that we would know about. Okay, so they have decreased breath sounds, hyperresonance, and a pneumothorax. So I mean that's really important. Uh, that all let's see. So sarcoidosis, I think that's a restrictive lung disease.
Okay, good.
And then chronic obstructive pulmonary disease is an obstructive disease. Bronchiectasis, I don't actually remember what category that falls into. But my gut's telling me COPD.
Okay. Yeah. So if this is just test taking strategy. The reason why I'm letting you kind of think through it is because I want you to kind of be like, okay, with the knowledge I do know, can I still get the answer correct? Okay. And that's the whole idea of test taking strategy. So you want to kind of stack what you can. So you're figuring out, okay, the risk factor is smoking. That might be the only one I kind of know. I might not know that COPD can lead to left-sided pneumothorax, right? But you work with what you got, right? Asthma, not so much, right? Of course, if you smoke, that can make your asthma worse, but asthma is usually, diagnosed pretty early in life, right? From allergens in the world, right? Bronchiectasis, right? There's a lot of things that cause bronchiectasis, right? Like, tumors, even COPD can lead to bronchiectasis, right? But practically chronic coughing and bloating of kind of your bronchioles there. COPD, right? Definitely fits with the 40-year pack hold history, and it can lead to left side pneumothorax if it's bad enough. Idiopathic pulmonary fibrosis is a restrictive lung disease, right? You don't know kind of what caused it, but you have fibrosis, and usually doesn't cause pneumothorax. Sarcoidosis is going to be an autoimmune disorder, right? So you're gonna have other things like hilar lymphadenopathy, right? It's more of a restrictive kind of lung disease look. You can have skin disorders. You can have all sorts of things with sarcoidosis. It doesn't really fit a smoking history. So yeah, COPD is going to be your best answer choice here, right? So questions, concerns about this? I think you worked through this pretty good, even though that you might not know every specific thing about a diagnosis, but I think you worked through this really, really well.
Is bronchiectasis restrictive or obstructive?
This should be more of an obstructive standpoint.
Obstructive.
But yeah,
Okay.
you get kind of recurrent infections, cystic fibrosis, immunodeficiency can cause respiratory less associated with spontaneous pneumothorax. But yeah,
Okay.
but it
So
caused
this,
dilations. Yeah.
yeah. So this patient is having a pneumothorax, whereas like a bronchiectasis patient, that would be like kind of more of a maybe like like a bacteria or something like that, like
Yeah.
a sort of pneumonia or something like that.
Yeah, so bronchiectasis, a lot of things can cause it, right? What I mean by cancer, so you have a blockage, right? So just kind of a general in medicine, anytime you have issues with homeostasis, a blockage in a vessel, a blockage in airflow, a blockage in drainage of your gallbladder, any kind of thing that causes stasis, right? Causes fluid or air to stay still will get infected, right? And so bronchiectasis, right? If you have a tumor or you have pneumonia that's really bad that doesn't resolve, right? You have autoimmune disorders that bloat up kind of your bronchioles really big and it traps bacteria in there, right? It can cause, that dilation and coughing and chronic coughing of nasty, nasty, wet cough, right? And so, this doesn't really fit that picture in this particular sense. So,
Okay,
yeah,
gotcha.
multiple things can cause
And
bronchiectasis.
then, sorry, one more question.
Sure.
So on resonance, so hyperresonance, and then like what could you talk about just resonance in general?
Yeah, yeah, yeah.
Clinical exam.
So, talk to me. What do you think? What do you think hyperresonance means?
So I admittedly kind of get these mixed up a little bit, but so is this our tapping like on a patient's back?
Yeah, so tactile firmitus, right? Yeah,
Okay.
to me, right. So one of the things you can use is here. So let's see what kind of our assistance is. Physical sound heard upon percussion of the chest that is louder and lower in pitch than normal. It is also associated with cases like pneumothorax and emphysema. So yeah, so this is your percussion, right? This is you tapping on the chest and how it resonates or vibrates,
Okay.
right? Which makes sense. If you have a pneumothorax, there's a bunch of air in there, right? So if I were to flick a larger balloon, it's going to make more sound, right? Because there's more air. So that's why they call it hyper resonance.
Okay.
Right?
Now with like a pneumonia and we tap that, what would that be? Would that be
Yeah, you can.
hyporesonant?
Yeah, so you can have a little bit of hyper resonance there too, right? So for instance, right? Let's see. I was gonna type in. What am I gonna type in here? Pneumonia. Um, on chest percussion. See, it may dullness, right? It's gonna be more dull, right? Because
Yeah.
as you percuss it, right, it's kind of like you're percussing. Like imagine flicking a water balloon versus an air balloon.
Right.
You get the
Right.
it's gonna be like a doink sound instead of like this like airy kind of vibration. Does it make sense? It just makes a different sound.
Yes. Yes.
So
Gotcha.
so I wouldn't call it hyper or hypo resonance. They're gonna describe that as a dull sound of percussion.
Okay.
So
So we'll have hyperresonance or like a dullness. Gotcha.
okay, perfect.